All right. Hi, everybody. Happy Friday. Welcome to the COVID-19 learning series for long-term care. I'm Sarah Metcalf. I'm a program manager in long-term care, and I will be moderating today's session. Just a reminder that this session is being recorded and will be posted on the COVID-19 intranet page for access later on. This is also where you can access previous sessions if you missed them, or we also have a YouTube channel now for public access if you'd like to watch recordings. First of all, I would like to acknowledge today that I am a visitor on the working traditional unceded territory of the Lekwungen people, also known as the Saanich, Songhees, and Esquimalt peoples. Please take a moment and reflect on and acknowledge the land that you're joining us from today. Thank you for taking the time to join our learning series. Today we're going to be talking about clinical management of COVID-19. And we would really like to get your feedback on today's session as well. So I'll be posting a link to a short survey in the chat box for you to access. The link was also sent out in an email about today's session. Our panelists today are Dr. Manville, our long-term care medical director, Dr. Jabahari, our long-term care medical coordinator, and we've also got three people from our COVID response team. Marlene Montgomery is our manager of quality assurance and contract monitoring. Deb Harbour is a project lead for the patient ambassador program and visitor policy. And Della Roberts is a clinical nurse specialist for palliative and end-of-life care. If you have any questions as we go through today's session, please just post them into Slido. You can get to that at www.sli.do, and the event code is #clinicalmanagement. I will now hand things over to Marina, who is just going to go through a quick presentation about clinical management.
Excellent. Thank you, Sarah, and thank you to our panelists for joining us today, as well as our participants taking part. So today I have just a short presentation regarding clinical management. And let's see if we can pull it up. There we go. Can I get a thumbs up that you've got my PowerPoint? Great, thank you. So clinical management and long-term care came up as a topic of interest for one of our learning series from a number of groups. So today we're hoping to touch on a few key objectives with regards to clinical management. We'll go over our long-term care COVID-19 clinical order set, discuss the importance of advanced care planning, as well as most conversations in the context of a COVID-19 diagnosis. We'll look at some clinical care considerations for your site, as well as introduce the role of hypodermiclysis and how it can be applied to COVID-19 management. We'll finish our discussion with discussing a bit of end-of-life care and transitions that you may notice in a person who has entered their dying time, and open it up to our panelists to answer your questions, as well as bring forward some of the lessons that we've learned from our outbreak experience. So in case you didn't know, we do have a clinical order set for long-term care. You can find it, you've got the breadcrumb sort of pathway there on the side. And what it is, it's a 2-page clinical order set for use in long-term care for people with mild COVID-19 or severe COVID-19. The definitions being that when someone requires oxygen support, that they'd be considered severely ill with COVID-19. Overall, right now, what we're seeing is the goal of care management is that a person, a resident, is cared for in their long-term care home setting as long as possible, as long as that is in alignment with their goals of care and most status, and that the site is able to meet their current medical needs and symptom management. The first page of this clinical order set is talks more about organizational things in terms of most status, admission and discharge considerations if you're having to transfer this person, and some communication requests. Some highlights from the clinical order set are things like monitoring. So vital signs twice a day are considered the minimum amount of times you'd be doing a full set of vitals on a person with COVID-19. This may be increased based on, or decreased actually, but based on the resident status as well and goals of care. There is mention of oxygen therapy. So in many long-term care homes, we have the use of oxygen concentrators, which can deliver oxygen levels up to 5 or 6 liters per minute. So these order sets give direction for providing oxygen therapy up to a 6 liter per minute maximum, and with goals for O2 sats. So in a person with no lung disease, aiming for O2 sats over 92% is the goal. For somebody diagnosed with COPD or potentially other lung diseases, O2 sats are tolerated between 88 and 92%. When you're monitoring a resident and you're not able to meet these goals, this is then a key communication point to discuss with the most responsible provider about their person's oxygen needs and how they're responding to oxygen therapy. With COVID-19, we know that there is not a cure, but there is ways that we can support symptom management. Some of the symptoms that are common with COVID-19 are breathlessness, and that can be managed with low doses of Dilaudid to help support breathing and comfort. If somebody is considered to have severe illness, then dexamethasone, it would be your first-line corticosteroid that can be offered. Prednisone is considered a second-line treatment. For some people, dexamethasone may need to be given subcutaneously, in which case there's some additional orders and considerations for that, but overall it can be offered PO. For fever, we do have antipyretic coverage as part of the discretionary orders for long-term care. And again, that's coming down to your careful monitoring of the resident and being able to provide symptom control. It's important to know we're maximizing the treatment available on site, and that we're considering transfer only if medically indicated, and that this is in alignment with the resident's goals of care. For goals of care or most status, it's important to remember that most is one piece of a whole bunch of conversations that have been happening. And most isn't consent to transfer and it's not consent to treatment, but it does give you an idea of what broad goals a resident may have. If your site is on outbreak, or specifically if you have residents who are positive, this is a really key opportunity to revisit goals of care with your residents and be able to document them so that those conversations can be captured and help inform decisions moving forward for residents who are positive. And also it's a good check-in time for residents who may not have positive status. Some general questions that you might use to open a conversation about goals of care could be things like asking the resident or their substitute decision maker what matters the most to you. What do you understand about COVID-19? Or what are your goals or wishes for your care? It's important to know during these conversations that you're coming from a place of curiosity and asking more questions rather than telling a person, because you want to be able to share information that is in line with where the resident or their substitute decision maker is at, rather than taking sort of a top-down and telling approach with these conversations. Some other things from a clinical perspective that you can think about are what would transfer to acute care offer that can't be offered in long-term care. In many cases, what can be offered in long-term care is within the same coverage of what would be offered in acute care, with the exception of intubation or higher oxygenation requirements. So many, or actually the majority of symptoms can be managed here in our long-term care homes. And also the last question here is is really coming down to, daily assessment and understanding of where the resident's at, and are their symptoms currently being managed with the care being provided at site. And these are frequent conversations that are happening between, whether it's yourself as a care provider, with the providers who are helping to guide the care for these residents who may be COVID positive, as well as with your care teams, to make sure people are coming together to provide person-centered care that really is meeting what the resident is looking for. There is a couple resources available on our intranet to bring your attention to. On the MOST Hub, which if you just type in MOST on our search bar, you'll come up to their page. They have a number of resources for advanced care planning. One of the COVID specific ones that's quite good is called Vital Talk, and it's a COVID conversation guide for communication around a positive COVID status. When you're thinking about clinical care and you're thinking about it like for what your site can provide, there's a few things to keep in mind. So part of clinical care involves equipment and what equipment you have available. We know from our outbreak management that equipment that is usually needed in larger amounts are vital signs machines or nurse on a stick, depending on your terminology. And the reason why you might need more of these is because if you do have someone who's COVID positive, you don't want that equipment coming in and out of their room. So ideally, people are going to have their own equipment in their room to reduce the risk of transmission of COVID droplets on equipment in between residents. So some suggestions for, that you could do right now at your site are to really like scour, your storerooms and your drawers and look for all that equipment that you have available to you to use, whether it's, manual BP cuffs and stethoscopes, pulse oximeters that are portable, and to have a good understanding of what equipment you do have, so that should you need more, you're able to ask for that during some of the outbreak meetings. We do have, some access to resources in terms of equipment sharing that through the outbreak response may be able to provide equipment, but it's really great to know at the site level what you have available for use. Oxygen concentrators are also an important piece of equipment for people who require oxygen. Most of our long-term care homes don't have the direct oxygen hookups like we see in acute care. So we need to know how many concentrators are available at a home, but also where to get more if needed. So if your site has contracts with oxygen providers, this is a good time now to know if you can get extra oxygen concentrators on short notice and what that process looks like, or if that's something, if that's an identified need for your site that you wouldn't have a quick and easy way to order more oxygen concentrators if needed. As well as having a look at your oxygen supplies. So we're talking about nasal prongs, the long simple tubing, and potentially a simple mask might be useful equipment needs. I'll add to this list as well that subcutaneous butterfly starts are a piece of equipment that can be useful for not only medication administration, but for hypodermiclysis, which we'll be talking about shortly. AGMPs, so these are aerosol generating medical procedures. Oh my goodness, or AGAMPs. And these include nebulizers, CPAP or BiPAP. There was an ask early on in early days of our pandemic that when at all possible that providers consider the multi-dose inhalers, so the handheld puffers, instead of nebulizing treatments for residents as a way of decreasing the amount of AGMPs on the site. We know that there are residents that currently are on CPAP or BiPAP. For some residents, this might be able to be safely discontinued or switched over to oxygen. For others, it may not be able to be discontinued. So it's really important to know your resident population and the AGMPs you have on your site, and be able to have plans in place to be able to stop or adjust and make your AGMP load at the site quite a bit lighter. Medication review has come up in a few different ways, and it depends on the outbreak and it depends on what's going on at your site. It may be that a medication review is required for individual residents in terms of really looking at medications and ideally being able to decrease the amount of med passes that are required for a resident. So looking for ways that medication can be delivered twice daily instead of 3 or 4 times a day. This might be recommended at an individual level. It might be recommended for an area in your home, like if it's a wing that's been affected, or depending on the size of your home, it might be a broader recommendation tip for a broad review of medications for residents, just to decrease the number of med passes. This is for a few reasons. It's to decrease the number of times, a nurse needs to go into the room, and decreases the workload in the site, but it also decreases the number of interactions, which can help improve workload when working under strained conditions. Another piece to look at is non-essential labs or diagnostics that are happening. And in many cases for long-term care, this means people are coming into the site or residents are having to go out for these procedures. So looking at what is considered absolutely essential and needing to occur during the outbreak, or what could be safely delayed or rebooked for a different, safer time. Hypodermiclysis. So with a quick show of hands out there, how many people have heard of hypodermic? Oh, I don't have a lot of hands except for our panel. So hypodermiclysis is something, maybe you've heard about it, maybe you want to know more because it's a cool sounding word. I really like saying it. And what it is it's a procedure that can be used in long-term care with a high degree of effectiveness for short-term rehydration. And it's hydration through the subcutaneous layer, and it's helpful and has come to prove itself useful in the context of COVID-19, because some people during the course of their illness may become quite ill and unable to tolerate anything PO. And you get to a place where it's difficult to determine if a person is really sick with COVID or entering their dying time, and they may need a couple days of rehydration in order to make a better recommendation in terms of which way care is going to be going. So it's an appropriate intervention for mild to moderate dehydration. A few contraindications with hypodermiclysis are if a person is requiring rapid fluid resuscitation. So that would be, if somebody was in acute septic shock and needed multiple liters of fluid in an instant, this hypodermiclysis is not the way to go. If a person has pulmonary edema or congestion, which might be a side effect of congestive heart failure, hypodermiclysis wouldn't be a good option. Clotting disorders have been mentioned as a possible contraindication because it's a little bit invasive. There could be bleeding at the site, but it's not an absolute contraindication in this sense. Long-term care does have some supporting documents for hypodermiclysis. We have a procedure. It's titled under parenteral infusion therapy that guides the insertion, the administration and monitoring of subcutaneous fluids, as well as there is an order set for hypodermiclysis, which helps guide infusion rates and monitoring as well. For the procedure, you're using a subcutaneous butterfly insertion kit, and the site or the location of the insertion is really important because you need to make sure there is a subcutaneous layer there. You wouldn't want this being infused in a muscle layer because it's quite uncomfortable and causes a lot of irritation. So areas you'd be looking for are in the chest, abdomen, thighs, or upper arms for a nice area that is able to be pinched up and have that subcutaneous butterfly inserted. The fluids of choice are normal saline or Ringer's lactate, and they are infused by gravity. So because we're going into a subcutaneous space, which is occupied by subcutaneous tissue, the tissue itself helps determine the flow rate and the amount of fluid that any one site can receive. So it doesn't need to use a pump, which is good news for long-term care, as IV pumps aren't technically something we have at our disposal. And then the roller clamp can be used to adjust the flow rate as needed. Generally speaking, the flow rates are given in terms of a volume over the length of a day, with the maximum amount of fluid being 2,000 mils per site in 24 hours. One common side effect of hypodermiclysis is swelling at the site, and that this can be relieved with massaging and sort of moving those fluids throughout the subcutaneous tissue. So we know in our elder population that a diagnosis of COVID-19 comes with a significantly higher mortality rate than with the general population. And this is especially so for people living in long-term care, given the degrees of transmission that we've seen in some outbreaks. So for elders with COVID-19, the mortality rate is anywhere from 20 to 30%. But that also means that 70 to 80% of people are recovering. So for those people that are entering their dying time as a result of a complication of COVID-19, things that you might be looking for or noticing are increasing breathlessness that isn't being met with increasing oxygen needs or being able to administer dilaudid to support that. You might also see changes in breathing, such as rapid breathing and then slow breathing. Some of these are natural changes that happen with death, but we should be alert to them as signs of transition for a person in order to be able to start the correct treatments. Our long-term care end-of-life clinical order set offers similar orders to what the long-term care COVID-19 order set does, but it also includes treatments for nausea, for pain, for anxiety, and respiratory secretions that happen at the end of life. So you may find that this is a more appropriate clinical order set to transition to when someone's showing signs of dying. Other signs that you might see are changes in consciousness, so a person sleeping more. A natural change as a person is nearing death is decreasing their oral intake because their body doesn't need that intake of fluid and nutrition like it does, as it normally would when it's not dying. Pain hasn't been reported as a key symptom of someone who is dying of COVID-19. But treatment is obviously available through opiate use and the clinical order set there. This was a great hypodermiclysis article for anybody. I can copy and actually paste this link in the chat for anybody looking for more information on hypodermiclysis. And that's it for me, Sarah. I just wanted to sort of give a broad overview of some of the main topics around clinical management and open it up to our panel for those questions. Thank you.
Thanks so much, Marina. Yeah, so we're going to just be moving over to our panel. So if anyone has any questions, feel free to post them into Slido. I put the website in the chat box, or if you want to unmute or post your question in the chat box, I can also keep an eye on that. So we've just got a few questions in Slido to start us off. Panelists, the first question is, I thought all residents who were COVID positive were being transferred to cohort sites. Why has this changed? Who would like to take that question on? Margaret?
I can take that on, and people on the panel, please help me out if I get it wrong. But since I was around at the very beginning of the pandemic, obviously there was so much uncertainty fear about how to look after residents in long-term care. And we were also becoming more increasingly aware that the mortality rates were very high and a lot of residents were being infected with COVID-19. At the same time, PPE was scarce and our long-term care staff were not as comfortable as they are now, obviously using PPE, donning and doffing, and actually sourcing PPE. So there was a few major concerns about how our response in Island Health would be if we got an outbreak of COVID-19 in long-term care. And because of those factors, and also because people remember at the very beginning of the pandemic, the hospitals emptied out, emergencies emptied out, and we had no people, we had COVID wards set up with no sick patients. So knowing what was happening in the Lower Mainland and thinking that was going to be happening with us, we had conversations with acute care, and they were very willing to help us reduce spread in a facility and to support patient care by accepting residents if they became COVID positive. We were the only health authority to actually negotiate that with our acute care settings, regardless of MOST status. The other health authorities didn't actually have that process in place. And that was recommended by our public health officers as well. Our medical health officers, Dr. Manusik wasn't with us, but Dr. Murray Fife was very supportive of this as well. What changed as our pandemic progressed was the availability of PPE, our ability to support our sites with COVID coaches and the training with the simulations. What ended up happening, what we saw at other sites and in our sites, was an increasing confidence in being able to look after residents on site. Having said that, with our first outbreaks, we did transfer our residents to the hospital. I believe some was based on MOST status, but also was based on that initial process that we had in place. And we recognized also that some sites will have more capacity depending on their staffing to look after residents, especially at the beginning of the pandemic. So what's happening now is that acute care is obviously available to any resident who needs the appropriate care based on their MOST goals, and their goals of care. So that is still available to any resident who is COVID positive, whether they need that hospital bed or that hospital care for treatment of COVID or treatment of, for example, they had a hip fracture and they're COVID positive. That is available to any resident who requires it. And what we also know is that the best care for any of our residents is usually on site in their home. And I think that the amount of work and care that's gone into preparing our sites, our staff, to look after COVID positive residents has been immense. And I trust so much that our staff can do this work and do it expertly for the benefit of our residents. So that, I don't know if that's a long answer to a short question. And you can fill in if I've missed anything, please step in, panel.
I
Just
think
a
you
point
covered it.
that's, yeah, just a point about some facilities are, their actual physical layout allows for us to continue to isolate those who become positive, whereas others don't. So that's going to be a case by case and facility by facility discussion as well. So.
Absolutely. All right. The next question is about equipment. Where can I get more equipment for my site if needed? Don't know if somebody on the response team wants to take a stab at that one.
I'll take a quick stab at that one. So part of our response and our response team is to hook you up with personal protective equipment and with other kinds of equipment. So we've been able to help folks out with the nurse on the stick. I think that we've also helped out with some concentrators before, but certainly if there are equipment needs from that perspective, we can help out with that. So you just need to let your response team member know if you have that kind of need, and we'd be there if there's an outbreak to ask, what more do you need? And Marina made a really great point with especially the nurse on the stick, if people are on isolation, you don't want to be moving that equipment from place to place. So we would help you out with as many as we could that way.
Great, thanks, Marlene. And what medications are needed to have on hand if our site was on outbreak?
I can try and answer that. So, I mean, I think Marina went through that with the COVID outbreak. So obviously, oxygen is great to look at in terms of the supply of oxygen. Some of the sites contacted, some of the oxygen supply companies around and providers just to have backup concentrators beyond what they had on site. The limitation of that is often some of those concentrators go up to 5 liters per minute. So going up higher, if that's indicated, might be something to look at transitioning to secondary care or acute care if that's within the patient's goal. So oxygen supply is pretty much one of the first medications. Opiates, generally speaking, we have that in our contingency, medications, but just Dilaudid is the preferred opiate as a first line medication. And then the other is dexamethasone. And that's the one that we found that actually a lot of the sites don't have on their contingency. So well worth talking to pharmacy now and seeing if you can have that. It's a dose of 6 milligrams orally. And on one occasion, we needed sub-Q as well. So just to have a few sub-Q around, but mainly oral dexamethasone appears to be the main medications. Beyond that, there are recommendations about antibiotic use, which again, these are the standard ones, but we would look at once daily antibiotic regimens, something like moxifloxacin, or for upper respiratory tract infection if the physicians or staff feel that there might be a secondary bacterial infection developing. Usually symptoms of a new fever, a week in, might be something that would make one think that there might be a bacterial component. So that's looking at the order set, Marina. I don't know if I've left anything out, but that's what we've been looking at as our initial supply.
Great, thank you. And if a resident is on a CPAP that can't be discontinued, what happens? How does that impact their treatment?
Can I just clarify that question? Is this a COVID positive resident or on an outbreak site?
Doesn't specify. Let's say it's a COVID positive patient.
So that, obviously creates a whole level of consideration for the site and for the patient. This isn't, most patients obviously are using their CPAP at nighttime. So, if that COVID positive resident is diagnosed during the day, we can make plans for whether, what the disposition of that patient should be. So, there'll be phone calls to, I'm going to give a vague answer. I'm not going to say this is exactly what needs to happen, but there's going to be conversations between the staff, the physician, the family, and maybe, consultation with the respirologist about what to do with that resident before we say, you must have an N95 mask on any staff member who enters that room, because it's during the procedure and after the procedure that those aerosols are there. So, we'd have to really have some good planning surrounding that resident. And if there are no N95 masks available or fit tested staff, then there is going to be a consideration of where does this patient receive care. Similarly, what I've seen with a lot of sites, on the mainland is that, a trial of oxygen often will work because you actually have people monitoring the resident and you can monitor their oxygenation. So, there's some ways to sort of think about this rather than just this is immediate, this is what our procedures and this is what we do. There are some things that we can think about trying before we say this resident, has to be treated in an acute care setting. Having said that, if there are staff who are fit tested if this patient absolutely requires BiPAP, for example, something like that, and all the conversations have happened, we have to make sure that the staff are safe looking after that resident. That's the most important thing. And if that can't happen and that resident still requires, you know, those interventions, those AGMPs, then there's going to have to be a conversation between MRPs and acute care about what to do, you know, how to care for this resident and transfer. Anything else to add, Irfan, on that?
No, I mean, that's fair enough. I mean, most people who are on CPAP have it because of obstructive sleep apnea. So it's really the underlying diagnosis. And if that's the case, then just oxygen support overnight is appropriate. But if they have severe heart failure, or they're, you know, COPD, or, you know, significant cardiac, and also the other one is obesity. So then that, you know, that person can't really go without their CPAP or BiPAP machine. So you have to be, it's based on underlying diagnosis, and that's why, you know, it's case by case and has to be reviewed quite thoroughly.
Great, thank you. And how would that change if the person wasn't COVID positive but was in an outbreak area?
So great question. So having not had to deal with this myself, I'm going to answer based on what I think I might do with that site. But if this, you know, the site is on contact and droplet precaution, if the residents are isolated to their rooms, staff are you know, vaccinated. You know, the other piece is the vaccination piece really does add that extra level of protection for residents. So my thinking would be, you know, obviously we have to have this conversation about whether this is an absolutely, you know, crucial and necessary intervention, and if it is, given all of the, you know, isolation precautions that we're using, my sense would be that we don't change anything unless this patient develops symptoms. And Irfan, would you agree with that?
Yeah, again, so the one site we had, we did review everyone, even though they were in a separate unit. We looked at, so it's all pre-planning on the basis that, you know, what will happen if they are positive. So we took all those steps ahead of time. And if in this particular case, there was no spread beyond the initial units, and so we managed to put CPAP back on to those patients because we were ahead of the spread of it. So, but it's all that pre-planning and just being aware of how to manage all those patients who require it ahead of time. So.
And Marina, you've worked on the AGMP, is it the protocol or the work that you and Bevan were doing about how to manage a resident who has got AGMPs, and so that is a reference that sites can use as well to help them prepare.
Absolutely, and that's available on the COVID-19 long-term care page as a reference.
Perfect. Next question, I feel like is a good one for Della. If a resident is considered end of life and COVID positive, how can we support the resident and their family during that time?
Well, thank you. I guess first, fundamentally, long-term care sites are familiar with supporting people in their dying time. And I think so many of the things that you're already very skilled with and comfortable with are foundational, whether someone's dying of COVID, with COVID, or of other things. Similarly, knowing who that individual is and what their comorbidities are and what else is contributing during their dying time are important considerations. One of the things that we know is that the experience across the country is that the orders that you guys have for long-term care for end of life typically are sufficient as well for someone who is dying as well with COVID. And obviously they have this level of frailty that's contributing to why it is that infection is overwhelming them. So using those orders, as Marina has talked about, and then individualizing for depending if the person has as well congestive heart failure or who they are as an individual. I think the other kinds of things is considering obviously the essential visitor and who they need around them as they're moving into their dying time, and being prepared for more rapid change potentially, and making sure that you have orders in place and planning for escalation of symptoms. I guess the other kinds of things is just kind of knowing that this is involving a respiratory symptom, that we can expect also as their respiratory function is less efficient, that they will sleep more and be less aware. And that's, so we haven't found in frail older people when they're dying that this is, that they have a lot of distressing symptoms, and the two physicians on the panel can speak more of that. And finally, I guess I would say that support for family, because the worrisomeness of this and the media and everything, and just making sure they have good information and they are guided through this experience too, and reassured. So I wonder if there's anything that anybody else on the panel wants to add to that.
It's Deb, I can jump in just in relation to the family members as essential visitors and how they can be supported for those end-of-life visits. And if an essential visitor has already been designated and they have been in contact with the resident, they will be part of the COVID screening and testing. So they'll be able to get a swab, and if they're negative swab, they can be designated still as an essential visitor, and then they follow the PPE precautions. And then we hesitate, if there is a COVID positive resident, to have many family members visiting. So we could support that essential connection and then have virtual connections built off of that. So it would be setting up iPads and the whatever kind of virtual opportunities that the site has to link in other family members that may not be able to visit in person. Just to, yeah, and the response team, we can also support those types of care plans and putting a safety plan in place and identifying who is an appropriate essential visitor in those moments.
Thank you so much. We're at time, but we do have a couple more questions that I think would be good to touch on quickly. If any of you need to drop off the call, thanks so much for joining today. The session will be continued to be recorded and posted online afterwards. For those of you who can stay, the next question is, if there's a resident who is COVID positive and is unable to stay in their room, how can we manage this? I know that came up at one of our sites.
At every site.
Yeah.
It's really one of the biggest issues, and one of the things that people have struggled with the most. We've brought some of those leaders in to talk about, what their wins were. And I think, a redirection as cheerfully as possible over and over again is helpful. And then thinking about if folks do need to walk and get out of their room, how to mitigate those risks. So there have been people that are unable to be redirected, and they just really want to come out and sit in a chair or something. And so if there is someone that could be with them to just wipe off those high touch surfaces. If we've got an outbreak, there's a lot of attention being spent to that spent in that regard anyway. We could put, if the resident would tolerate a mask, they've also used those. Allow them frequent hand hygiene, make sure and bring them alcohol hand rub. There's really no way to keep folks in their rooms sometimes when they don't. So you've just got to mitigate the risk around that. But if you can engage the family members to see if there's anything that the elders might be interested in to keep in the room, if they don't have a television. Sometimes that's helpful even for a little while. Music that they've enjoyed from the past, those kinds of things. It's just the best you can do, really. It's a difficult, one of the most difficult things I think that there is. Marina, do you have anything you want to add about that?
There are a couple supporting documents about care planning for people with dementia who are also COVID positive that may be helpful and highlight a lot of the things that you said, Marlene. But I think it comes down to, and like you said, being able to mitigate the risk and also meet the individual needs of the resident and the safety of the staff. So there's a lot of creative ways that can happen. It's not a one size fits all, and really maximizing what you're able to do at your site in the interest of safety is key.
One of the things that we identified were the bed alarms in the middle of the night. Sometimes the wanderers will, they get the antsy legs and want to visit friends in the middle of the night. And so making sure that they do have a bed with a bed alarm.
Yeah, great point. Okay, a couple more quick questions. How can I safely care for the body of someone who has died of COVID? Are there any specific instructions around that?
There is the reference safe handling of people deceased people with suspected or confirmed COVID-19. I imagine that you're using that in long-term care, are you, Marina? So there is a really good reference about that and the fundamental is that you still continue your droplet and contact precautions right through to the care of the body until that body is transferred. So that's the most important. I don't know if anybody, and that is a really good reference for people. Anything else you want to add to that, Marina?
And there is reference to a shroud that can be used in order to be able to wrap the body safely for transport. I think a key piece to it is communication, clear communication with the receiving funeral home so that they can be aware of the safety precautions that they need to take on their end so that there's a smooth transition and care of the body from the site to the receiving funeral home.
Thank you. And the last question is about staffing. How many additional staff are deployed to a site during an outbreak? In my experience, this seems to be sort of a case-by-case basis. But does someone on the response team wanna speak to that a little bit?
I wouldn't say there'd be any additional staff, but we would, if you're in a situation where you've gone through everything that you can do as a site, you've looked at your sister sites, you've gone through your own HR, you've called back for overtime, then we can look at deploying island health staff, but we can't just sort of give extra staff. So it's not extra, but we'll try to keep you on a level.
Okay, so it'd be for covering shortages more so than sending extra people. Great. Well, that covers all of our questions. I just want to make sure I haven't missed anyone. Are there any other questions out there? All right, hearing no one. So thanks so much everyone for joining us today, and thanks so much to our panel for answering our questions, and Marina for giving us a great presentation. Happy Friday. Enjoy your weekend.
Thank you, everyone. Take care. Bye.
Thank you, everyone.
A great weekend.